So I think we're right here on time, ready for our next presenter. We are continuing with the Celebration of Scholarship poster presentations uh, this afternoon for our graduate students. So our next presenter is Tyler Thompson, and he is going to be talking about bladder temperature monitoring of patients undergoing total joint uh, arthroplasty. So I've been looking forward to this one for a while. We started talking about this quite some time ago. So Tyler, I will turn this over to you.
Okay, get my screen shared here. Is it showing up okay?
Yes.
Okay, great. All right, as she said, my name is Tyler Thompson. I'm a third-year anesthesia intern, and I did my DMP project on bladder temperature monitoring of patients undergoing total joint arthroplasty. Total joint arthroplasty was considered a knee or a hip replacement. My project was performed at a small critical access hospital in north central Illinois. The project idea was decided after speaking with the director of surgical services at the mentioned hospital. The director had brought to my attention that there was an increase in the number of surgical site infections of patients undergoing total joint arthroplasty. So I began researching the literature on risk factors for surgical site infections of patients undergoing this procedure. I came up with many interventions that can reduce the risk factors for infection, many of which were part of a surgical site infection prevention bundle. But for the sake of time and the size of the project, I decided to focus on temperature monitoring, while the director of surgical services focused on other ideas from the prevention bundle once I was done implementing my intervention. An increased incidence of surgical site infections of patients undergoing total joint arthroplasty at this critical access hospital prompted an investigation to reduce risk factors, as I said. Despite research and recommendations, perioperative hypothermia continues to plague patients, increasing the risk for surgical site infection and subsequently hospital costs and perioperative morbidity. Temperature sensing indwelling catheters provide a continuous, accurate estimate of a near core body temperature that may aid in better recognition and treatment of perioperative hypothermia. The effects of hypothermia on the body slow healing, increase surgical wound infection rates, increase length of stay, and increase costs. The use of core temperature aligns with the ANA's fifth standard, which states monitor thermoregulation when significant changes in body temperature are anticipated to facilitate the maintenance of normothermia. Furthermore, the National Institute of Health states that the most accurate temperature monitoring device should be used that is also the least invasive. So the following PICO question was used to guide the clinical practice change, and it's in patients undergoing total joint arthroplasty. Does the implementation of bladder temperature catheters improve the accuracy of temperature monitoring compared to peripheral skin monitoring temperature devices? Surgical site infections are pretty common incidents in the surgical environment, but they're 100% preventable complication. Hypothermia has been proven as a significant risk factor for the development of surgical site infections, which can be controlled by the anesthesia provider or the certified registered nurse anesthetist or CRNA. While temperature monitoring is a standard of care for patients undergoing anesthesia, there is not a standard monitoring device. The use of evidence-based equipment that has been shown to be accurate may provide the anesthesia provider with an increased ability to monitor for intraoperative hypothermia and subsequently reduce the risk for surgical site infections. To investigate this potential, a literature review was conducted to determine the significance of hypothermia of patients undergoing total joint arthroplasty, to examine the correlation between hypothermia and the rate of surgical site infections, and to explore which temperature monitoring devices have been shown to be accurate and represent core temperature. The literature review findings suggest that patients undergoing total joint arthroplasty are at an increased risk of hypothermia, and the use of bladder monitoring and dwelling catheters are accurate and represent near core temperature. As a result, the use of bladder temperature monitoring in dwelling catheters was adopted as the primary temperature monitoring device of patients undergoing total joint arthroplasty at this rural health facility. As mentioned, this was performed in North Central Illinois at a small critical access rural hospital. And the project looked at assessing 30 patients as part of a pre-intervention group and 33 patients that were part of the post-intervention group. The pre-intervention group had data collected on them through the data collection tool, which is on the poster. And then the post-intervention group collected data through the data collection tool as well after the implementation of the project. The Iowa model was used as a framework for this project. The Iowa model framework includes identifying triggering issues, selection of a purpose question, formation of a team, assembling, appraising, and synthesizing a body of evidence, and designing and piloting the practice change and integrating and sustaining change. The results of this project. So of the peripheral skin temperature monitoring, 13% of these patients were documented as being hypothermic during surgery, hypothermic being less than 36 degrees Celsius. And the average length of stay was 2.8 days. And 50% of these patients were documented as having postoperative fevers within 48 hours. Of the bladder temperature monitoring group, 57% of these patients were documented as being hypothermic during surgery, and their average length of stay was 2.6 days. 24% of patients were documenting as having postoperative fevers within 48 hours. When comparing the intervention groups, we can see that patients undergoing total joint arthroplasty with bladder temperature monitoring were shown to have shorter length of stays and lower incidences of postoperative temperatures greater than 100 degrees Fahrenheit. The incidence of hypothermia was identified in 19 patients with bladder temperature monitoring compared to 4 patients when using peripheral skin temperature monitoring. Bladder temperature monitoring has been shown in numerous studies to be an accurate temperature monitoring method that reflects near core body temperatures. Accurate temperature monitoring provides an opportunity to better recognize and treat intraoperative hypothermia. Hypothermia has continuously been associated as a significant risk factor for postoperative surgical site infections. Patients undergoing total joint arthroplasty specifically are at an increased risk for perioperative hypothermia because of many factors such as radiant, convective, and conductive heat losses, the sympathectomy that is associated with spinal anesthesia, and the high degree of skin exposure that is needed for these procedures. The implementation of this project provided an opportunity to successfully implement the use of a more accurate temperature monitoring device to a population at high risk of hypothermia. This project highlights the importance of utilizing accurate equipment to provide better care for patients. The identification and treatment of perioperative hyperthermia prevents an opportunity to prevent surgical site infections, which has been associated with an increased mortality, cost, and length of hospital stay. The use of bladder temperature catheters recognized hypothermia in 57% of the patients, while peripheral skin temperature monitoring only recognized hypothermia in 13% of the patients. The results of this project provided rural hospital the opportunity to permanently improve temperature monitoring and reduce patient risk and hospital costs. There were several limitations of this study. Firstly, the inability to directly measure the correlation between intraoperative hypothermia and surgical site infections was a significant limitation of the study. The ability to follow patients for 30 days to determine readmission rates for surgical site infections would provide a better correlation between hypothermia and surgical site infection. And ideally, a larger sample size of both study groups would provide an opportunity for more accurate statistical representation of the study groups. And then inaccurate or complete documentation of the anesthesia record was another limitation of this project. Today, now currently at this healthcare facility, the incidence of surgical site infections has decreased after speaking with the Director of Surgical Services, and they still are using temperature monitoring in dwelling catheters as part of its surgical site infection reduction bundle. Since my project's implementation and the literature that I provided her, they've also included other hypothermia prevention interventions, such as pre-warming their patients and warmed IV fluids. Lastly, I would just like to give a thank you to Dr. Gilfike, Dr. Dana Flatley, and Dr. Gephardt. I had a goal of getting this project done early. It was a goal since I started in the program. I really wanted to do that. And they all helped me facilitate that and rooted me on and helped me with my roadblocks. So I definitely could not have done it without you three. So I just wanted to tell you thank you, and I appreciate you.
So do we have questions from our audience today for Tyler and or discussion about his project?
I thought you did a really good job, Tyler. I don't necessarily have a question, but I just thought I would let you know.
Thank you. I
Really
appreciate it.
interesting study.
Thank you.
Tyler, thank you for the nice compliments. You did, great job staying on task. But it is worth mentioning that your critical access hospital urgently pushed you on as well.
Yeah.
Seeing the beauty of your project and being excited about it and giving you financial backing, that was incredible.
Yeah, so the facility was, they obviously wanted to cut down their infection. So the fact that they had somebody from the outside coming in and saying, hey, let me help you tackle this was really nice. So they kind of helped push me along. So I was able to get my interventions in there. And then there was a slight, the use of the indwelling bladder temperature catheters came out to about $1.19 more than the per patient, and they were willing to absorb that cost with no issues.
Any other questions?
It's Dr. Fike again. I wonder if you could just elaborate just for a second on how you use the interdisciplinary team on your project.
Explain that again, please. Or what was your question?
How did you use the interdisciplinary team on your project? What all disciplines were involved in moving this project forward?
Okay, so I definitely had to use management, the director of surgical services. So I worked with her, to get this idea going. And then I had to, work with the CRNAs and anesthesiologists, kind of tell them what I was doing, why I was doing it, just to make sure that they were using them. And then I actually just had to, speak with the surgical techs who set up the rooms to make sure, that they were taking the new device that they ordered and putting it in the room. So to make sure that they're getting the bladder temperature indwelling catheters and not the standard catheters that they would use. So it was definitely kind of talking with multiple groups to make sure everything went smoothly. And for the most part, it did. I had some issues with some documentation that was, not thoroughly documented, that I couldn't use some of those patients. But other than that, it went really well.
Well, Tyler, I just want to congratulate you on finishing. Very excited to have seen this project come to fruition. I think you did a great job. So we'll allow your audience to offer their congratulations to you, and then we will finish up this session, and our next session won't start until 2:30.
Thank you very much.
You did fabulous.
Nice job, Tyler.
Great job.
Thanks.
Congratulations, Tyler.
Yay, we're done.
Congratulations.